Let's jump into it. Let's talk about the respiratory system. We've mentioned some of this already, and so it intertwines a bit. Respiratory system is responsible for reoxygenating the blood cells. Pretty much it. It's not responsible for transporting the blood or anything. It's just reoxygenating the blood. So we breathe in oxygen, and that oxygen goes into the lungs and goes down there to that capillary bed that we've already talked about. Diffusion takes place. That's pretty much the respiratory system. That's what it is. It's a little bit more complicated when we start talking about breathing and the other things that the respiratory center does. But on the surface, brings in carbon dioxide, excretes brings in oxygen, excretes carbon dioxide. Oxygen in, carbon dioxide out. Not really that difficult. Remember the picture, the bronchial tree? You can see why it's called a tree. And these bronchioles get smaller and smaller as they go towards the terminal end. And the terminal end of this bronchial tree is the alveolus, or the alveoli. And then again, another good picture of the lung. Remember, the right side has 3 lobes, and the left side has 2 because of the heart's in the way. These lobes are independent of each other, so if something happens to one of the lobes, they can remove it. You're not going to breathe as well because you're losing surface area of the lung tissue, but you're still going to be able to function. You can live without a whole entire lung. You just won't breathe as well. And then the terminal end that we talked about here, you have this little picture right here, this bronchial come in, and then you have this grape-like structure. When they're all together, they look like you can picture these alveolus as grapes. You know, you hold up the stem of grapes, thing with grapes on it, and then you have the stems going into the grapes. Think of those stems as the bronchioles going into the grape, which is the alveolus, and then you have this cluster of grapes, or this cluster of alveolus. You have billions of alveolus in the lungs. You have a huge, huge surface area in the lungs. We stretched it out one time. We went from, because we got really bored and we measured it out. We lined students up from past the cafeteria going towards the auditorium all the way to the front door across from each other. And I think they were 12 feet across from each other. And that was the surface area of the lung. I want to say we figured it up. The actual surface area of the lung, if you were to stretch it completely out, was bigger in square foot than the Dallas area. It's huge in square feet. Don't quote me on that, but I think that's what we eventually figured out. But these alveolus, they sort of cluster here in lung. When we talk about respiratory emergencies, then we'll get into some problems down in here and now these alveolus, especially with cigarette smoking. Cigarette smoking, if you know, how many of your parents smoke? Yeah. I'm not concerned what else they smoke, but they smoke cigarettes. But that's a joke. But cigarette smoking's horrible. I'll bag on cigarette smokers all year long. They smoke in front of you, with you in the car, with you in the same presence. Your parents do that? Your parents do that? You need to tell them to stop respectfully, because like if this was a cigarette, the end that lights up, my son called it the cherry end, but the end that's red, when I do this, I go, and it turns really red, that end, according to the American Heart Association, is more cancerous than me inhaling the smoke. So if you're right here, and you're breathing off the results of this end of this cigarette, you're in more danger of getting cancer than I am, and I'm smoking the cigarette. So that whole secondhand smoke thing is really true. They're putting everybody in danger. That's more carcinogenic or cancer causing than actual smoking. And it trashes the lungs, makes you smell bad, everything else. But so this alveolus is where the diffusion takes place. The air comes in through the bronchial. It stores here in the alveolus until the bloodstream picks up the oxygen. This little picture up here, I'll give you a bigger picture of this later. This just represents the upper and lower airway. The upper airway is considered the nose, the mouth, and down to in the throat or the pharynx. It's the upper airway. Everything below the vocal cords is considered the lower airway. But I'll give you a better picture. That doesn't really give you enough space to look at it. But remember what the epiglottis is, correct? The nose comes in through the mouth, or nose, depends on what avenue you're breathing with, goes into the pharynx or the throat. Epiglottis opens and it goes into the trachea. And the epiglottis is that leaf-type structure that sits over the larynx or the vocal cords, protecting us when we swallow food and water, liquid. Then you have the trachea that's anterior to the esophagus, and it has small rings of cartilage around it to keep it upright. The esophagus is just smooth. It doesn't have any cartilage in it. It comes down and it bifurcates, or it splits into two at what's called the carina in the left and right main stem bronchus. And then from this bronchus, it just breaks down into the bronchioles, smaller and smaller and smaller bronchioles. They have little names for them. And then to the alveolus, where the gas exchange takes place. And then there's sort of a picture. I think we looked at that last time, right? Well, that's a cadaver, yeah. But the diaphragm here, and then the two lungs. This area right in here is where the heart is, and then the pericardial sac, peri meaning around, pericardium, so it's a sac around the heart, and the mediastinum, this area right here that's in the middle, is called the mediastinum. Medium, and then the middle. So let's talk about respiration, because there's a couple different things that we look at. When we breathe in, I haven't quite figured out how to get a new thing. Okay, so when we breathe in, that's what I was going to do. Thanks for reminding me. When we breathe in oxygen, when we breathe in atmospheric air, the air in the atmosphere is 21%. Oxygen. All right? It's 78% nitrogen. Very good. So you have 21% oxygen, 78% nitrogen. When we exhale 16% oxygen. So we use 5% of what we breathe in. Inhalation and exhalation, there's two parts. Inhalation is considered an active process. Exhalation, or breathing out, is considered a passive process. There's a process that goes in the brain that we'll just briefly mention. We won't mention too much of that, but you have to remember that there's a sort of a mechanical function and a neurological function to breathing. So we're going to talk about the mechanical function right now. When you have atmospheric air, you have atmospheric pressure. We know that, right? And at sea level, the atmospheric pressure is 760 millimeters of mercury. That's at sea level. So we're going to use that number because I don't know what the atmospheric pressure here is. So let's say we're at sea level. The atmospheric pressure is 760 millimeters of mercury. On the inside, you have an intra. Intra means inside. Okay? Intrathoracic pressure. So the pressure that's inside the thorax you have a pressure there. Now, when I go to breathe in, what I'm trying to do, because gas will always move from a high concentration to a low concentration, right? So when I breathe in, I'm trying to create a container that is has less pressure than atmospheric air, so the air will come in. Everybody good with that? So what happens is the brain signals the body, hey, it's time to breathe. So when it does that, it sends those neurons down there to start the breathing process, the mechanical breathing process. So what happens is the diaphragm contracts, and when the diaphragm contracts, it contracts in a downward area, all right? And it makes the intercostal muscles contract. And when they do, it pushes the thorax out forward. So you have a downward motion of the diaphragm, and then you have the pushing out of the rib cage from the intercostal muscles. What is that making this container, the thorax? What is it doing to that? It's making it bigger, right? It's making this container bigger. So we look at the thorax just as an air container, right? So the brain says, hey, let's breathe. Sends the signals down. The diaphragm contracts. The intercostal muscles push the chest wall out forward, and the container gets bigger. If we didn't change the volume any, and we made the container bigger, what happens to the pressure? Boyle's law. We didn't change the volume, we just made the container bigger. So what happens to the pressure? Lowers, right. It decreases. The pressure decreases. Because the container's bigger, no change in volume. So now the pressure is less in the thoracic cavity than the atmospheric pressure. And where will the air come in? The air will go in, right? So your signal comes in, hits the diaphragm contracts, chest wall comes out, thoracic cavity gets bigger, the pressure drops below atmospheric pressure, and air comes in. Everybody good with that? Okay, so air will come in, it will come in. The brain goes, that's it, that's enough, let's exhale. All right? It will send signals for the diaphragm to relax. The diaphragm will come back up to its original place. The intercostal muscles relax, and the thorax will come back to its original shape. Now, what has happened to the container? It's got smaller. The container's decreased, and so what happened to the pressure? Huh? Right, the pressure increased. So now the inside, the intrathoracic pressure is now higher than atmospheric pressure. So where's the air going to go? Out. The air is going to go out because the air will move always from a higher concentration to a lower concentration. So once the intrathoracic pressure is greater than the atmospheric pressure, the air will go out. Everybody good with that? All right? Everybody see the way that works? Very important that you get a good grasp of how that air moves in and out. And it's all due to pressure changes. That's the mechanical part of breathing. The neurological, or what I call the brain part of breathing, is a little bit different. We'll pick that up later. We don't need to worry about that right now. We just know that the brain, the respiratory centers, is on the brain stem, and it sends signals down to start this breathing process for us. That's all we need to know about right now. We'll get into more of the brain stem function later. It gives us something to talk about later, okay? When we talk about the respiratory. So is everybody good with that? Everybody's got a good grip on how the mechanical part of that works? All right. So it makes exhalation more passive, the more passive breathing. It's not active. Active breathing is when the diaphragm contracts on inhalation. And then once we breathe air in, like we've already talked about a little bit, oxygen enters the alveolus or the air sac, and that's where the diffusion takes place. Carbon dioxide and oxygen change places. If we're in the pulmonary system, right, we have a high amount of oxygen in the alveolus and a low amount of oxygen in that pulmonary capillary. So when that blood comes through there, the oxygen will diffuse across in the pulmonary, and the carbon dioxide will enter into the alveolus. Everybody good with diffusion? That diffusion process? Here's the slide I've been looking for some time. Let's say that this is a capillary bed. You have capillary beds all over your body. Right now we're talking about pulmonary capillary bed. A bed is just, that's probably a little confusing for you, the capillary bed. The bed is right here. This is where this venule coming down right here, see, and this arterial connect. They connect in the bed. So you have deoxygenated blood coming down here that needs more oxygen. It comes through this bed, gets reoxygenated, and is pumped out back to the heart. The alveolus sits right here in the center. And well, that's not really true to say. The alveolus, these capillaries lay over the tops of the alveolus. They're covered in it. If you looked at, like, let's take our grapes again. So looking at our grapes, that alveolus right there, the capillaries would be like if you had a gazillion spiders spinning webs all over the grapes. That spider web could represent the capillaries. They lay over the top of the alveolus, so diffusion can take place through these very, very thin membrane walls. All right, and this is a good picture to sort of grasp here with this alveolus covered up with these capillaries. So deoxygenated blood comes through, high in carbon dioxide. Inside the alveolus is low in carbon dioxide. So the carbon dioxide is going to cross, the oxygen is going to come out, and it's going to be pumped through the rest of the body. Everybody good with those baby steps with diffusion? It's a pretty fascinating system. Now, I mentioned before, we have to know what's normal and abnormal. A better word is adequate and inadequate. Normal, abnormal, adequate, inadequate. So adequate breathing is probably what everybody is doing in here. Nobody's having trouble breathing, right? Adequate breathing, we're all breathing right. We're breathing the normal adult respiratory rate, which is 12 to 20 times per minute. You'll see that in your notes in a few minutes. You can find them. So that means we're breathing adequate. Adequate breathing means that we are breathing the normal rate, that we have good symmetrical. Symmetrical means what? Symmetrical? Same. So symmetrical rise and fall of the chest. So we have good, both sides of the chest, rise and fall. Rise and fall, symmetrical. We don't have one rising and one falling like that, which is called paradoxal movement. Paradoxal means opposite, but rise and fall. All right? So we have good rise and fall, symmetrical rise and fall of the chest. And we're not using any accessory muscles to breathe with. And I'll talk about the accessory muscles when we talk about inadequate breathing. And For an adult, all I want you to know for right now is the adult. Normal adult respiratory rate is 12 to 20 times per minute. We typically breathe about 16 to 18 times per minute. Now when we go into vital signs, the respiratory rate is one of the vital signs. You have to count the person's respiration because we want to know if they're breathing normal. If they're breathing 28 times per minute, is that normal? No, because normal is 20. Anything above 20 is abnormal, depending on the circumstance. I could run down the hall and run back, and I would probably be breathing more than 20 times a minute. Is that abnormal? That's normal for the circumstance, because I just got through running. It's not abnormal for me to be breathing faster. But if I start breathing faster like that, just standing here, then that would be abnormal. Right? So 12 to 20 times per minute. Some good symmetrical rise and fall of the chest. No use of accessory muscles. Now, above 20, let's say you're breathing 30 times per minute. What is that called? Hyperventilation. What's hyper mean? Yeah, above. So hyper means above. So hyperventilating, you're breathing above the norm. Hypo means what? Hypoventilation. Less or below. So hyper, hypo. A couple of those H's for you. A couple of those prefixes. Work on. Now when we talk about inadequate breathing, we look at the respiratory effort and the use of these accessory muscles. So I'm having trouble breathing for some reason. Let's say that I'm that chain smoker and I smoke 5 packs of cigarettes a day and I smoke them on oxygen. So I'm having trouble breathing. And so I'm going to start using my accessory muscles to breathe. I have great effort to breathe. When we look at this, so I'm breathing faster than what I should be. I'm using my abdominal muscles to help me breathe. Right? Adults are not abdominal breathers. Babies are. Babies use their abdominal muscles to breathe. Adults do not, or should not. That's considered an accessory muscle. The other muscles would be considered accessory muscles would be the neck muscles. Don't ask me which ones. I mean, that sternocleidomastoid muscle. I don't know. Up here, right? So you're tugging. You see them go like this, and they're tugging with these muscles here. All right. Other signs of inadequate breathing would be nasal flaring. So the patient's nares flare out, and it's not in conscious control. I can't say, oh, I'm having trouble breathing, let me flare my nares. You know, it's abnormal. I mean, it's just unconscious control. And then the other thing that you would have would be the tripod position. The patient will be bent over, sort of flaring their arms out, trying to get that thoracic cavity bigger, correct? I mean, when you get through and you were in sports or something, and they told you, hey, when you get through running, put your hands over your head. Nothing like that, right? What do they tell? Why do you do that? Why do you put your hands over your head? Get that thoracic cavity bigger so you can get more air in, right? The bigger it is, the more air will come in because you're decreasing the pressure, intrathoracic pressure of that cavity by raising your hands up. Correct? So that's inadequate breathing. These are just, again, intro things to get you sort of heading that direction. When we talk about respiratory emergencies, we'll spend some time talking about the different respiratory emergencies. Right now, we're just sort of doing the introduction to it. Some new vocabulary for you. Inadequate breathing. Paleness is not necessarily new for you. Everybody knows what pale is, correct? Cyanosis, C-Y-N, C-Y-A-N. What's that? Blue. Right. So it's a bluing. That doesn't mean that you smurf out. If you smurf out, most people are not with the living anymore. But you get cyanosis, peripheral cyanosis. One of the places that you will see is in the fingernail beds. The fingernail beds will start turning blue, and the mucous membranes inside the lips will start turning blue. And they'll get pale. That's a sign of inadequate breathing. Again, I got to sort of check it out here to get this thing with pale and not pale, normal and not normal. So that's always good. Get a good visual thing. What is pale? What's that? Not pale. It won't take long for you to pick it up. You see patients come into the hospital, you go, whew, what's wrong? I mean, I can tell when you guys don't feel well. I don't have to ask. I can look at you and tell when you don't feel well. One, it's in the eyes. You look at the patient, the eyes, and then you can tell they don't feel well. They lose that white part of the eye. When you start having fever and you don't feel well, you lose that luster in the eye. That's the one way that you can tell if someone doesn't feel well. You can look at them and you can just tell. The other is that they're pale or something. They don't look right. The other thing is cool and clammy. This is abnormal for the skin. Skin should be warm, pink, and dry. Everybody is warm, pink, and dry. Cool and clammy, what I tell you is cool for cool and clammy. I think it works. Next time that you're going to cook some ramen or some noodles, spaghetti or something, cook you up a little extra, leave it in the pot, run cold water over it, and then stick your hand in it. That's cold and clammy. That's what cold, clammy skin feels like. Once you feel cold, clammy skin, you'll know for sure. Because you go up and you touch the patient, you go, good. Yeah, you go, it feels a lot like you're holding a loogie, a cold loogie. You're sitting there going, you know. So the agonal respirations, and this is very good. It's just scenes right before death. Agonal respirations we'll talk about in CPR, but agonal respirations are a snoring type. It sounds like you're about to cough up that loogie. You're going like that. And what it is, it affects the brainstem. It's due, agonal respirations is due partly to brainstem herniation. That's where the brainstem is being forced down that hole in the skull that we looked at the other day. That it's not big enough for the brainstem to go through, but it's being squeezed down through there. It's at the end of life when you start having agonal respirations. It's due to brainstem herniation. It's when the brainstem is being forced down through that hole that's in the bottom of the skull. So, you know. Other signs that you say, we talked about nasal flaring, cyanosis, using the abdomen muscles here. What leads to inadequate breathing is dizziness, anxiety, confusion due to the lack of oxygen. You're not getting enough oxygen into the system, and then all these things start to take place. If you're breathing too fast over here, you get the numbness and tingling, right, of hyperventilation. Hyperventilation is because of the fact that you're blowing off too much CO2. Your body has a certain amount of carbon dioxide that it has to keep. The normal CO2 is 35 to 45. If you blow off too much CO2, then you're out of balance. You're out of that homeostasis. So that's what happens with the hyperventilation. Someone starts to hyperventilate, they get numbness and tingling, their hands start to draw up. It's because they're exhaling too much CO2. You need to get them to slow their respirations down. That's why they typically breathe in a bag. They rebreathe their carbon dioxide so it will increase their carbon dioxide level. We'll get into all this a little bit later when we talk about respiratory emergencies. One thing I want to mention to you again, signs and symptoms. The abbreviation for signs and symptoms is just S over S. A sign is something that you see. Respiratory distress, you can see that. vomiting is a sign. A symptom is something the patient has to tell you. You can't see it. Nausea. Can't see it. Vomiting you can, correct? A sign is also something that can be measured, like a blood pressure. So a sign is something that can be measured or seen. A symptom is something that the patient has to tell you. When we look at the pediatric airway, and we'll do some stuff just for pediatrics, the airway is quite a bit smaller. So when we learn to open the airway, we do it a different way. And the tongues in pediatrics are huge. The tongues always get in the way. So there's some differences in the airway anatomy that we have to be aware of, just not right now. Like it says, the trachea is more easily obstructed, and it's softer, it's more flexible, so you have to be much more careful with the pediatric airway when you're doing certain airway maneuvers with it. And the pediatrics are all cartilage anyway. They haven't quite developed in the bone. You guys still have a lot of cartilage in you. You don't get all calcified until like your 20s or something. So there's quite a bit of difference there. We won't really talk too much about inadequate breathing in children yet, but you start seeing a seesaw effect in the abdomen, severe retractions. I've got some video I'll show you there with that one picture is worth 1,000 words, right? So you can see these kiddos that are having trouble breathing. This picture here looks pretty cool. Let me flip off the light. Anybody know what that is? Somebody got trachea. This is the trachea. This is the bronchus right through here. This is an endotracheal tube that is stuck in there. This structure right here, the red structure, is the epiglottis. I'm going to try to have these people come back out again. Looks like a catfish there, doesn't it? Yeah. One year they brought all these organs out and talked to us about these organs and stuff. Well body program, and then it was pretty cool. They brought the lungs and the heart and the brain out. So it was pretty neat. But just give you sort of a realistic, sort of meaty view of the trachea. It's got still a lot of muscle and stuff attached to it there. Formaldehyde. That's all it smells like. All right, let's briefly talk about the neurosystem. Anybody want to be a neurologist? Go into neuromedicine? Oh, good. No crazies in here. You have to be, you guys could do it, but the neurological system is so complex that most of these people who are neurologists, they're so smart, they're stupid. They're just crazy. They're just super smart people. The neurology is a very complex part of healthcare. That's why they make the big bucks. But essentially what happens is it gives us voluntary and involuntary control. The central nervous system, the CNS, central nervous system, is composed of the brain and the spinal cord and spinal nerves. You have the peripheral nervous system, which is the arms and legs. Periphery is the arms and legs. So you have the central nervous system and the peripheral nervous system that we will talk about. There's just that cross-section of the brain again that we've already discussed. The spinal cord, the brain stem, the little brain of the cerebrum, and the big brain, the cerebellum. Remember, the cerebrum controls all the fine motor skills. The cerebellum controls all of the gross motor functions. And then the brain stem controls vegetative functions. And there's the top side. Looks like a butt, doesn't it? But there's the back side of the cerebrum. Well, I bet if I cropped that down and asked you what it was, 50% of you would say butt. Ugly butt. Here, when we get into CPR, we will talk somewhat about strokes. I think everybody has a common knowledge of what a stroke is, right? But this brain, when we start talking about stroke, I want you to go back and mentally look at this spot on the brain here. See this black spot that's right here on the brain? That's where this patient has had a stroke. That means that this part of that tissue is dead. It can't be regenerated. It's dead. It's dead tissue. So whatever this part of the brain controlled no longer happens because that tissue is dead. But the brain is so complex that it will pick up in other parts of the brain the function of that part that is now dead. But that's what happens here. Due to a clot or something or lack of oxygen, this is what takes place. The same thing takes place in the heart. They have a heart attack. If someone dies of a heart attack and have an autopsy, the coroner will open it up, look at the heart, and wow, he's got this big dead spot on the heart. So they know that this person probably died from a heart attack. When we speak of stroke and heart attack, we talk about surface area. How much surface area of the heart or brain did it encompass? This is a fairly small surface area, right? So that means that this stroke could be, in layman's terms, categorized as a little stroke because it doesn't encompass a large part of the brain. Or a little heart attack, if that was the heart, right? So it gives you sort of a visual picture of what takes place there. And then this picture here is just holding the brain up, and you can see the spinal cord coming down. Can everybody see this picture right down here at the bottom? It's called something. It's named after a horsetail. I can't remember the exact name. But all these that come out of here are spinal nerves that come out the bottom, and they sort of branch out towards the bottom, right in the bottom of the back. That's probably why my back hurts so much. I think I've got a compressed disc back there, and it's probably pushing down on one of those. So it just sort of spreads out right through there. So we talked about central nervous system, peripheral nervous system. Autonomic means automatic. So this means the nerves that we don't have control over. In the central nervous system, you're going to have nerves called cranial nerves. And these cranial nerves control large functions. I think it's the third cranial nerve that controls the vision. You have a cranial nerve that controls speech. You have a cranial nerve that controls a bunch of different things. All right? We won't learn the cranial nerves, but we will talk about the cranial nerves. One cranial nerve that we will talk about is the vagus nerve. The vagus nerve branches off into what's called the phrenic nerve, and that nerve lays across the heart. And so when I say, give you a term, call it a vagal response will slow down the heart. It means a vagal response activates that nerve, and then as that nerve lays around over the heart, it slows the heart down. That's the purpose of a vagal response, is to slow the heart rate down. You could create a vagal response right now by holding your breath. If you hold your breath and bear down like you're trying to poo, you will have a vagal response. In fact, if you just... Okay, central nervous system, brain, spinal cord, spinal nerves. You don't really need to know more than that for right now. In the peripheral nervous system, you have a different set of nerves. You have sensory nerves and motor nerves, and in between these, you have a loop, because the natural process is for the nerve cell to send the response back up to the brain, and the brain to send the response back to the to the cell. So if I want to pick this stick up, my brain is sending a response down to my hand, and I do that, and then send a response back to my brain to tell me to do this. When we talk about sensory and motor nerves, there's like a little feedback system there. Remember when you were young and your parents did one of these things they shouldn't do, and there was something hot there, and they sort of drug your hand towards it and said, don't touch this, you know. Well, duh, it's hot. So what happens is, let's say that stick's really hot, and I go down to pick it up. My sensory nervous system is going to pick that up. It's going to tell my brain, it's going to say, oh, that's hot. But it's not going to send the signal all the way up to the brain and back down for me to do this. It's going to send it to the motor nerve. So the sensory nerve goes hot, and it gets that short feedback to the motor nerve, and my motor nerve is going to do this. So I don't touch the hot stick. Make sense? Same way with blinking. See how you blink? Or you're driving down the road, and the rock comes up, you blink, you close your eyes before the rock actually hits the windshield, correct? All the time. You go, and you hear the rock hit the windshield. It's that motor sensory thing. Your eye's going to shut, protect the eyeball before. It doesn't have to go to the brain. It shortcuts it, so it doesn't have to go to the brain in this motor and sensory system. And then just sort of a picture in definitions, sort of the peripheral and nervous system. We'll get into this when we talk about the fight or flight. You get sort of a sympathetic response. When I say sympathetic response, I mean a central nervous system response. So you get a sympathetic response, sympathetic nervous system, you get a central nervous system. It's a little different, but we sort of interchange it for ease. And then there's some nerves there that sort of branches out. You can see all the different nerves. Some of them are quite big. You know, they're like small little ropes as well. And you have them running all through your arms. That's when we start taking vital signs. I'm going to tell you about these nerves that run through your arms that you want to be careful with. Nothing to panic over, but you don't want to be horseplaying with those blood pressure cuffs. So, I mean, that's all that we're going to really brief, just those quick definitions about the central and peripheral nervous systems. We'll talk more about all that as we get further into the class. Quickly, the digestive system. Our digestive system begins in the mouth. As soon as we start chewing food, the enzymes in our mouth starts breaking the food down. All right? We swallow the food. Once we swallow the food, it changes not into food, but they call it a bolus. And it goes into the esophagus. Once it goes into the esophagus, you have this action called peristalsis. And peristalsis is an action like a snake eats. Everybody seen a snake eat something? They sort of like that, right? And the little bunny just sort of gets moved down the big snake's belly, right? Section at a time. That's what happens when we swallow food. It just doesn't swallow and drop down into the stomach and splash into the hydrochloric acid, right? It's pushed down through the stomach and it winds up in the stomach. I can never keep the times in my head, but I think it stays in the stomach 4 to 6 hours or something like that. Continues to be broke down. Almost no digestion takes place in the stomach. Once it leaves the stomach, it enters... Oh, my picture. Is there a picture next to here of the organs? Yeah. Okay, that'll work out for now. It's not as good as this one. Once it gets in the stomach, it goes into the small intestine. It starts breaking down. In the small intestines, which is this part in the middle here, okay, that's where digestion takes place. And so the body keeps breaking it down and keeps pulling out what it needs, the nutrients that it needs, okay? And then it moves into the large intestines. And then the large intestines, or the colon, is essentially just a poop factory. It's for waste product. You get no digestion in the large intestine. It's just there to collect waste. And it moves through the large intestines and then out. This whole system from tube to tube is the digestive system. Okay? And there's a multitude of problems that can take place from here to the other end that we don't have you don't want to go into today, and we don't have time today. When we get there, we'll talk about all these digestive disorders as they sort of come up. Right? But it stays in there, and it sort of moves. The other organs that we look at is this little green-looking organ there. And when we do talk about this, I'll get you a better picture. But this green organ here is the gallbladder. It secretes gall into the small intestine. And the gall helps break down fatty foods. Any of you guys not have a gallbladder? Or you don't? So you can't eat really fatty foods, right? You take medicine. You just got to watch your diet. Yeah. So you can't eat. You can't eat all those big cheeseburgers, those big fatty meals. You get sick in a dog, right? You just think you have abdominal pain. Oh, over here you get the pancreas. The pancreas is responsible for insulin production. More than that, but primarily what we'll speak of in this class is just for insulin production. So insulin helps break down the sugars that we eat, so we can use the sugars. What I want you to start looking at is what is located in all the 4 quadrants. So you guys have the technology there to get the good pictures. But I want you to start looking at all the organs and what's in the quadrants. You have the liver that's up into the right upper quadrant, that's tucked up underneath here. The appendix is sort of towards the midline, down in the mid right upper quadrant. The spleen, okay, in picture representation, they put the spleen right here in the left upper quadrant. The spleen is actually located in the medial. The side, lateral. The spleen is more lateral, over here. The liver is responsible for all the things that we put in our bodies. The liver has to break it down. It detoxifies everything, the good and the bad that we put in our body. It detoxifies. The spleen is primarily for red blood cell production and destroying red blood cells. And then there's sort of a weird picture of it. Don't worry, we'll watch the videos. We have a much better picture than that. It's good for lunch. I think the skin is the endocrine system. We don't talk about the renal system yet, but the kidneys, located in what's called retroperitoneal. Peritoneal space is the belly. Retro meaning behind. So your kidneys are essentially right here in your flanks. From each kidney, you have 2 ureters that come out down to the bladder. And the bladder holds the urine until it builds up enough urine, and that sphincter muscle's giving you signals to go to the bathroom. And then to go to the restroom, it goes out through the urethra. So that's the urinary tract. Anywhere in there, you can have a urinary tract infection. Anybody ever had one of those? Pretty painful. So you can get infections in there. The skin just helps protect us. It regulates heat, gives us protection from microorganisms. Makes us look better. Just think if we all didn't have skin, we just had muscle tissue there, all of us would look sort of freaky, right? Well, not really, because everybody would look that way. Yeah, someone with skin would be the abnormal one. Ooh, you got skin. And then the sort of the different layers of skin. We probably won't talk too much about the skin until we get into trauma and we talk about burns. But you have the epidermis, the top layer, the dermis, sort of the subcutaneous part of that, or the fat, nerve cells in there, and then the muscle. So just, I mean, you can be briefly familiar with the different layers, but you really won't see that too much anytime soon. The endocrine system is very complicated. The endocrine system, two things that we will talk about in great detail is insulin and epinephrine, but the endocrine system controls the whole body. The whole hormone system of the body is controlled by the endocrine system. What I usually have you guys do, if we get this far, is in your groups, like you'll take a gland, you'll take an endocrine gland, and then your group will take an endocrine gland, and so on, and sort of do a little presentation of the endocrine system. So you sort of teach each other the endocrine system. When we look at it, we have the pineal gland. We talked about that one, right? That's the one that puts you to sleep when I turn off the lights. We did speak of that, right? Okay. The hypothalamus. The hypothalamus is a gland that really controls the other glands, controls body temperature, heat. You have the pituitary gland, which is about the size of a pea. I've actually seen one at the cadaver lab. They got one out. They try to dissect these pituitary glands, and they usually break them apart. But I got to see a whole one. Anyway, the pituitary gland is considered the master gland. It gets a signal from the hypothalamus, and it tells the other glands what to do. Essentially, that's why they call it the master gland. The thyroid, people with thyroid problems have problems regulating heat, weight, that sort of thing. The pancreas controls the insulin production. You have the adrenal glands that sit on top of the kidneys. They secrete epinephrine, adrenaline into the body, like when we have that fight or flight or that sympathetic response. Those adrenal glands kick in and force epinephrine into the body for that sympathetic response. And then you have the boy and girl glands. All right. Any questions there on the endocrine? I mean, that's just like a 2-minute here it is type thing, but very, very complex. There's a doctor called an endocrinologist. If you are an endocrinologist, all I know is that you're really smart and you make a lot of money, because that is a high specialty like neurology is.